Hello, I'm Dr. Anil Gudi, consultant in assisted conception at the Homerton Fertility Centre, London. Today I'm going to speak about two papers, both of which have seen answering a very important question. We know that in women with polycystic ovarian syndrome or PCO morphology, in IVF, freezing of embryos may give us a significantly better success rate and reduce the risk of ovarian hyperstimulation. The question which we do not know at present is in what happens in normal responders. Is it better to freeze or is it better to do a fresh embryo transfer? Studies have been going on across the world looking at this answer. Again, the evidence was split in between, with people saying the fresh transfer is the only transfer that should be done in non-PCO patients, but also in cases where there is a poor responder, fresh transfers would be better. We're not talking of poor responders at present. We are talking of what happens in non-PCO patients. Again, a huge study done in China, clearly under the supervision of Richard Allegro. Non-PCO, first cycle, 20 to 35 years, a normal menstrual cycle, no PCO, no uterine abnormalities, Puragon and Puragon as the FSH, antagonist protocol, HCG trigger, 5 or more oocytes to be collected were randomized. Those at risk of ovarian hyperstimulation were not included. Frozen, 1,077. Fresh, 1,080. 1 to 2 embryos transferred at cleavage state and later on, as I believe the laboratories got better, to a blastocyst stage. Luteal phase progesterone was given in a fresh cycle, and FER, frozen transfer, if it was natural, no luteal phase support. It was medicated, then he had estrogen and progesterone. Let's look at the results. Absolutely stunning. Frozen, live birth rate of 48.7%, fresh 50.2%. Twins, very similar. Singleton pregnancy birth weight, very similar. Not that the frozen had more birth weight. First trimester loss, very similar. Second trimester loss, slightly lower in the frozen region. What does this study tell us? It tells us, with such large numbers, there is no significant difference between fresh and frozen. Second trimester loss is lower in a frozen embryo replacement. Moderate and severe hyperstimulation is less in the frozen. In PCO again, freezing may be better. In non-PCO, it seems that both do the same. What do? I prefer freezing embryos. Now the reason is different in normal responders. One, it allows us to delink two treatments. Allows us to take away the phase of aggressive stimulation, of hormonal intervention and surgery, and move the embryo transfer to a much more stable state, with women more confident, less stressed, and probably that may give us the same results, but it may make the entire treatment experience much better. That is something which we need to consider. But what is more important? Are your labs good enough to be able to say we will only freeze? Are your labs good enough to say we will culture to blastocyst transformation? And if they can't, then probably fresh transfer may be better. Now another study, again this was done in China, and this was looking at fresh and frozen in non-PCO patients. IVF transfer in fresh or frozen cycles in non-PCO patients. Single center study, recombinant FSH used 150 to 300, HCG trigger planned, luteal phase support in the form of progesterone, randomized. Results again, very surprising. Frozen, live birth rate of 33.8%, fresh 31.5%. Miscarriage 6.4%, fresh 3.8%. Ectopic 1.5% in the frozen and 3.3% in the fresh. Again in this study, no difference in fresh or frozen in non-PCO patients. I think the evidence is slowly coming through. If your labs are good, fresh or frozen does not make any difference.